Bismillahirrahmanirrahim. Doctors, let's we start our today's class and today's class on surgery, class 1. And today's topic, basically we will discuss about the trauma part. And trauma we will follow the Kaplan surgery, Kaplan notes. So go through with that. So here is Kaplan step 2 CK, Kaplan surgery. So this basically in this book we will follow mainly trauma chapter. Trauma chapter is extremely important and a lot of questions from this part as well. So trauma chapter we will follow the Kaplan. Okay, and general surgery we discuss general surgery in during our GIT classes, right? Mostly we discuss, but left out a few topics we will discuss in our today or tomorrow class. We will try to finish. And general surgery, major portion we already done during the acute abdominal pain chapter from John Murtagh. Trauma part, other surgery part is deficient in John Murtagh, so that's why we follow the Kaplan. And the section 2 is important. So section 2 is important, surgical vignettes. So surgical vignettes is important. So after completing the chapter, please you have to go through the surgical veneer. So that's why you know how to apply your knowledge after theory. So basically, this is the MCQ's clinical scenario wise, and every chapter uh, after theory, uh, say Kaplan surgery have surgical vignettes. So so must at least you must go through the trauma surgical vignettes as well and general surgery. Another, if you want, you can go. Okay. So chapter one, uh, chapter one trauma. For example, patient got accident after RTA. So after RTA, what are the things you have to consider? Always you have to consider A, B, C, and D and E. This is a primary survey. Primary survey, and we have secondary survey. Secondary survey. Okay, later on we will discuss about secondary survey. So, okay. So in A mean airway. Always you have to firstly focus on airway. Either airway is intact or not. B mean you have to later on after airway you have to focus on breathing. Breathing. C means circulation. So that's why you have to approach stepwise. D mean there is any like neurological problem. So disorientation like neurological problem. So you have to uh, see the patient. And A mean exposure. Exposure like either patient are in a wet cloth, maybe patient goes in hypothermia, and hypothermia at the time may be cause of death. So that's why you have to expose the patient as well to check out the injury and as well as about the cloth. If cloth is wet, so as soon as possible, according to environment, you have to change. So in case of, for example, hypothermia sometimes cause of death. So that's why you have to change the cloth. So these are basically in primary survey. What about the secondary survey? So secondary survey include head to toe examination. After primary survey, you have to go for secondary survey, head to toe examination. So this include in the secondary survey. Palpate the whole body, check about the injury from the whole body, start from the head to toe examination. So now we are going to start at the primary survey one by one. We will discuss. Oh, sorry. Okay. So primary survey, we have airway. Firstly, the first step is evaluation of trauma is the airway assessment protection. Airway is considered protected if the patient is conscious, speaking is normal tone. And airway is mean compromised or unprotected if there is expanding hematoma or subcutaneous emphysema in the neck and patient voice is gurgly breathing as well, and Glasgow coma scale is less than 8. After you found that the patient Glasgow coma is less than 8, breathing is gurgly, noisy, or during the palpation you find out there is emphysema on the neck. So it means there is airway compromise. So after if you found that the airway is compromised, you have to go for airway management first. So for that, always go with intubation. So and if intubation is impossible or not available, you can go with cricothyroidotomy as well. So definitive airway management, and it depend upon the injury. So there is a rapid sequence induction, orotracheal intubation with monitoring of pulse oximeter, and in the presence of cervical spine, orotracheal intubation can be done as long as the head is cured and in line stabilization. So another option if nasotracheal intubation over fibrotic bronchoscopy. So if firstly you have to try the intubation, right? If uh, unsuccessful, intubation is unsuccessful, go for cricothyroidotomy. So after you can go with cricothyroidotomy. And in patient, in children pediatric age group population less than 18, tracheostomy is preferred over the cricothyroidotomy. So this one you must know. So tracheostomy will be considered if the patient age less than 12. Why? Because due to the high risk of airway stenosis. So this one is all about the airway. So airway is compromised, go for intubation. If intubation is unsuccessful, go for cricothyrotomy. Okay. So this one is about the airway management. And in pediatric age group, tracheostomy will be considered as compared to cricothyroidotomy. Okay, move to next. Second is breathing. So breathing sound indicate the satisfaction ventilation, absence or decreased breath sound, indicate pneumothorax or hemothorax. So basically we will auscultate the chest to listen the chest sound with the help of stethoscope. If there is any absence or decrease in breath sound on the auscultation, we will think as there is a hemo or pneumothorax over there. So that's why we have to go with chest tube placement. And for pulse oximeter, we will pulse oximeter indicates the oxygenation. Okay, hypoxia or scan into the airway compromise. So pulse oximeter tell us about the oxygenation. And breath sound, we will listen with stethoscope. Okay, move to next. Doctor, the most important, one more things. At the time of trauma, at the time of trauma, the cause of death is head trauma. Cause of death is head trauma. So remember this. Okay. Later on, after airway breathing, we now have to see about the circulation. Maybe the blood is lost due to the hemorrhagic shock or anything else. So we have to consider about the circulation. Either patient in shock. So what is the definition of shock? So if BP is less than 90, tachycardia, low urine output, uh, doctor, am I audible, right? Voice is fine. Doctor, am I audible? Okay, okay. So about the circulation, this one, if you find out this situation, we will consider as patient is in shock, hemodynamically unstable, hemodynamically unstable. If BP is less than 90, tachycardia, low urine output. So it means circulation is compromised. Maybe it depends upon the causes as well. So patient in shock will be pale, cold, shivering, sweating, thirsty, and apprehensive. So this is the clinical picture of shock as well. In trauma setting, there is hypovolemic, secondary to the hemorrhage are the most common scenario, or cardiogenic shock, secondary to the pericardial tamponade or tension pneumothorax. So what about the hemorrhagic shock? So hemorrhagic shock cause collapse neck vein due to the low central venous pressure. Important point. So first is hemorrhagic shock. Second one is cardiogenic shock. So in cardiogenic shock, you will find out there is elevated CVP pressure, jugular venous distension. So in hemorrhagic shock, the CVP pressure will be low. Okay, because blood is lost, so volume is decreased in the body, so that's why central venous pressure is decreased. But in case of cardiogenic shock, there is uh, blood is okay, but cardiogenic means there is problem in the heart as well. There is a pumping problem, cardiac output decrease. So that's why the JVP will be raised. Maybe and due to in case of cardiac tamponade, there is a obstruction in the outflow tract. So that's why the patient goes in state. So in cardiogenic shock, there will be elevated JVP. Okay. In case of pericardial tamponade, so in cardiogenic shock, there are two things. One is pericardial tamponade, two is tension pneumothorax. Okay, and in both there will be CVP will be raised. Okay, so how we can differentiate between either it is pericardial tamponade or tension pneumothorax, because both are CVP will be raised. In case of hemorrhagic shock, okay, the CVP pressure is low. We can classify that. But how to differentiate between pericardial tamponade or tension pneumothorax? So in pericardial tamponade, there is no respiratory distress. Respiratory, no problem, no dyspnea, no any respiratory feature. Okay, but in while in tension pneumothorax, because tension pneumothorax lungs is involved, so there is significant dyspnea, loss of unilateral breath sound, or tracheal deviation. So if these features are present along with raised GVP, we will think as it is the tension pneumothorax, because these features present in tension pneumothorax. But in pericardial tamponade, there is no respiratory distress, no any feature. Does it make sense, doctor? Doctors, make sense, right? Any question? Okay, so while once you diagnose the patient with shock, you have to you have to resuscitate as soon as possible. So we have so treatment of shock, including the volume resuscitation and control of bleeding in the or you can go with AD depending on the injury or available resource. Okay, so stop the bleeding and give the IV fluid. Volume resuscitation is inability with uh, initially with 2 liter of ringer lactate solution unless blood products are immediately available. Okay, so for example, the patient in shock, so immediately 2 IV line, 16 gauge. Okay, peripherally you have to insert peripheral. For example, in case of if peripheral vein is not available, vein not see, peripheral vein you not able to see. So then next, then we have two types. Uh, we have two way to resuscitate, in which we have introitious, via we can give fluid through introitious vein, as well as we can go with venous cut down through saphenous vein, through saphenous vein. So through saphenous vein we can give fluid. Okay. And in introitus, anyone you can go with, either you can go with venous cut down through saphenous vein, or you can go with introitious vein. Okay. So then later on you give the fluid 2% ringal lactate solution. You have to resuscitate. Okay. If, for example, in case of both are you are failed to resuscitate through both vein, both fail. If both fail, you can't able to find this vein. Then what is the next step? You can go with a central line, central vein line. Okay, through internal jugular vein. Okay, so internal jugular vein. This is the last uh, resort to resuscitate the patient. So CVP, you can go with internal jugular vein, resuscitate over there. Okay, move to next. So this one is about the resuscitation. Should be continue until the BP normalize, and you can read. Then 16 gauge or greater, we discussed two large IV bowl. You have to IV line, 16 gauge should pass, and inserted acceptable alternative is saphenous cut down, saphon vein cut down, or you can go with the subclavian or femoral vein. Get it right. Uh, so this thing we discuss. Okay, so move to next. One more things. For example, what is mean of BP? BP mean there is BP is equal to cardiac output multiplied by TPR, right? Mean arterial pressure is equal to BP, right? So BP depend upon the cardiac output and TPR. So cardiac output further depend upon heart rate and is depend upon the stroke volume. So stroke volume further depend upon preload, and it depend upon contractility. Okay. So preload, if preload will be decreased, so the cardiac output will be decreased. So when preload will be decreased, when there is a decreased volume in body, decreased volume. In case of hemorrhagic shock, right? Hemorrhagic shock. So decreased volume in the body. And second condition, when there is obstruction, outflow tract obstruction. In case of obstruction, like as we discussed earlier, so obstruction like there is tension pneumothorax. So tension pneumothorax, or the second one is there is cardiac tamponade. Cardiac tamponade. So basically, what happened in cardiac tamponade? Here is, for example, there is uh, here is heart, for example. So in as we know that there is surrounding pericardial cavity. So the fluid is accumulate in the pericardium. Okay, in case of pericardial tamponade. So this will compress the heart. So it will ultimately compress the left ventricular outflow. So it basically compress the heart. So that's why heart didn't able to pump the blood to the superior vena cava. So that's why the outflow, there is obstruction problem as well due to the compression of the pericardial fluid. And in tension pneumothorax, there will be air in the lungs as well, and it will compress the activity over there. So that's why there is obstruction problem. And contractility problem, like there is MI infection. For example, in MI, there is cardiac muscle didn't able to pump the enough blood which supply to the body. So that's why in MI, the contractility will be low. So that's why stroke volume will be decreased, cardiac output will be decreased, and patient goes in shock. Ultimately, BP low and goes in shock. So this is the basic concept uh, for your understanding. So that's why explaining. Okay, move to next pericardial tamponade. The things we discuss: clinical diagnosis can confirmed with the ultrasound. Management required the evacuation of the pericardial fluid by synthesis. Pericardiocentesis. Okay, so we will insert the needle at pericardium space and fluid we will take out. Okay. So pericardial window or thoracotomy go in later on stages if there is massive fluid over there. Fluid and blood administration while evacuation is being set up and helpful to maintain the cardiac output. Okay. Move to next tension pneumothorax clinical diagnosis based on physical examination as well. And on chest X-ray, you will find out there is plaque, air in the lungs, collapsed lung. So management required will be immediately decompression. So doctors, these are MCQs as well. So immediately decompression, needle decompression. Decompression of pleural cavity initially with the large bore needle, which converts the tension to simple pneumothorax. And chest tube we will place in case of if there is a secondary cause. Okay. So secondary cause we will go with chest tube, but for the tension or primary cause we will go with the large bore needle decompression. Okay. Okay. So these are about there is obstruction problem, pericardial tamponade and tension pneumothorax. In pericardial tamponade, there is no respiratory distress, but there is a problem in the uh, obstruction over there due to the compression of the pericardial space on the heart. Okay. So heart will be compressed. The yellow is the heart, so heart will be compressed, shrink over there, didn't able to perform their normal work. And in case of tension pneumothorax, there will be also obstruction due to the massive air in the lungs. So that's why it compress the heart as well and lungs. So the JVP will be raised in this case because the fluid is enough and there is obstruction problem. So superior vena cava fluid will be uh, blood is enough in the body, but didn't come into the heart due to the obstruction, due to the compression of the pericardial space. So this one is about C shock causes as well and their amendment. So hemorrhagic shock, there is hemorrhage over there, so that's why the CVP will be low. So you have to resuscitate as soon as possible. There is secondary survey. So ABCD evaluate and any immediate life-threatening emergency dress. So secondary survey composed to complete physical complete. So you have to head to toe examination basically. Head to toe, head to toe examination. Okay, so which composed of complete physical exam, evaluate for the occult unsol injury, followed by the chest X-ray or pelvic X-ray. This can be survey meant with the imaging studies depending on the mechanism of injury and any other required. Okay, so doctors here is about the cricoid cricothyroidotomy. picture you can see in between the cricoid cartilage and thyroid cartilage, we can go with cricothyroidotomy through via cricoid membrane. Okay, here is trachea. So circulation, these things we discussed. Pericardial tamponade, with things discussed. Secondary way, no, we are going to discuss that. Okay. So there is a link of NSW of different types of shock you can go through. Uh, the things is important we discuss. Okay. So okay, in a non-traumatic setting, shock, hypovolemic due to the massive fluid loss, blunt peritonitis, pancreatitis, and other causes. And the other cause due to the contractility, cardiogenic shock caused by the myocardial infarction as well, includes the myocardial infarction. And clinical picture is hypotension, tachycardia, and oliguria, right? So with high CVP and distended neck vein, treat with the pharmacotherapy, circulatory support, and DD is essential because additional fluid and blood administration in setting is lethal. The things we discussed. Vasomotor shock is anaphylaxis. So in case of uh, so here I write the formula of the BP. BP is equal to cardiac output multiplied by one more thing. There is TPR. Okay, total peripheral resistance. So in case of sepsis, peripheral resistance. If in case of sepsis, for example, anaphylaxis shock, anaphylaxis shock. So it goes in state like sepsis. So anaphylaxis shock, basically this sepsis is like there is any infection, any infection bacteria over there. So it lead to the anaphylaxis in the body. So when anaphylaxis in the body, it will dilate the blood vessel. So when dilation of blood vessel, so decrease cardiac output to the body. So when more blood in the extremities because vessel is dilated. So in this shock, you will find out there is a warm during examination, warm extremities. For example, hand, foot, there is warm. Extremities will be warm. But another shock, you will find out there is cold peripheral extremities. So the important point in anaphylaxis shock, on examination, you will find out there will be a warm extremities due to the anaphylaxis. There is dilation of blood vessels, so blood pool up in the peripheries. So it decrease the cardiac output as well. Didn't goes into the heart due to the decrease dilation of blood vessel. So that's why shock. So vasovagal shock, anaphylaxis, and maybe due to the spinal anesthesia or spinal cord transaction can uh, uh, can cause circulatory collapse as well due to the dilation of blood vessel. Pink and warm. So this is important to differentiate from other, and low CVP because blood is pull up in the extremities. So central venous pressure will be low ultimately. Treat with the we can go with the phenylephrine because this is vasoconstrictor, period dilated vein, and restore peripheral resistance. Okay, move to next. Country survey head to toe. So head to toe will be at the head trauma. Most of the patient will be die at the spot due to the head trauma. But few patient, 5-10%, if they are surviving, so you have to uh, consult immediately as soon as possible. So penetrating head trauma is required surgical intervention. So as soon as possible, there is surgical intervention and repair of damage. In, ca- in case of linear skull are left alone if they are closed. Okay. Open fracture required, wound closure. So open fracture will require wound closure. Linear fracture you can left alone. Penetrating, you have to go for as soon as possible surgical intervention. And most of the patient will be die if there is head penetration, a head penetrating trauma. and linear fracture you can left alone, and open fracture the wound closure. If communicated or depressed fracture, treat in the OR, operating room. So anyone with the head trauma who has become unconscious, so this point is also important. So anyone with head trauma who has unconscious, get a CT scan to look the intracranial hematomas. If there is neurologically or a negative intact, they can go home, family, and awaken frequently during the next 24 hours to go into the coma. So if there is unconscious patient, head trauma, unconscious, get a CT scan to look for intracranial hematomas. And if there is a negative CT scan, negative CT scan and neurologically intact, they can go to the home. Family will awake and subsequently during the next 24 hour to make sure there is a not going to coma. So इट मीन्स कि अगर एक पेशेंट का आपने सीटी स्कैन किया उसका ठीक आ गया तो आपने उसको घर भेज दिया तो लेकिन विद इन 24 आवर्स तक उसमें नजर रखनी है कि ये दोबारा तो अनकॉन्शियस स्टेट या उस तरह में तो नहीं जा रहा. अगर जाएगा तो आपने कंसल्ट अगेन हॉस्पिटल आना. ओके, मूव टू नेक्स्ट. Sign of fracture affecting the base of skull. So base of skull fracture is typical. So if base of skull fracture, so you have to what are the feature of base of skull fracture? So you will find out there is a recognize, rhinorrhea, otorrhea, ecchymosis behind the ear. You will find out there is a battle sign. Ecchymosis, if they are present, bleed over there, we also called as battle sign. So for this, we have CT scan is required to rule out the intracranial bleeding and should be extended to the include the neck to evaluate for cervical spine. Expectant management is ruled and antibiotic are not required. So important point. Important point is firstly you know about the recognize. So this one is recons basilar skull fracture, basilar skull fracture, and when base of the skull is damaged, you will find out there is recognized. This one is recognized. So see here, रेकॉन मीन लाइक ये एक परिंदा ये एक जानवर भी है तो इस तरह का ये इसकी आइज होती हैं जिस तरह इसकी आइज है ना चमगादड़ इसे कहते हैं रेकॉन आइज टाइप. ओके, एंड ऑटोरिया बैटल साइन एकिमोसिस बिहाइंड द ईयर उसको ये आपको फीचर साइन नजर आएगा. ठीक है, एंड देन CSF ओटोरिया एज वेल, हेलो साइन ब्लड एंड CSF. ओके डॉक्टर्स, सो ये उसके साइन है मैंने आपको दिखाने के लिए वो बताया था कि आपको पता हो कि बेसल स्कल फ्रैक्चर में रेकोनाइज कौन सी होती है इस तरह की नजर आ रही होती है, पोस्ट ऑरिकुलर एफिमोसिस होती है एंड CSF ऑटोरिया होता है. ठीक है, ओके. एंड देन द इम्पोर्टेंट वन इफ यू फाउंड find out there is a fracture of the skulls and arteria, these feature show CT scan will be had is required to rule out the intracranial bleeding. So that's why you have to go with CT scan if patient is in conscious state. Extend to the include the neck to evaluate for cervical spine. Expectant manage is rule out. Okay, so these are two. Okay. Move to next. Neurological damage from trauma can caused by three components. Initial blow, subsequent development of hematoma displays the midline, later development of the increased IC50 due to the cerebral. So there is no treatment for first other than preventive. Surgery can realize the second. And okay, so doctor, what are the indication? For example, if patient presenting to you with head trauma in rural areas, रूरल एरियाज लाइक ऑस्ट्रेलिया के अंदर जिस तरह वो लाइक जिस तरह पाकिस्तान के अंदर एरियाज होते हैं ना लाइक जो वो पसमानदा एरियाज होते हैं लाइक कोई सिंध के हो गए कुछ पंजाब के हो गए कोई बलूचिस्तान के कोई इस तरह के, तो इनको ऑस्ट्रेलिया के अंदर रूरल एरियाज कहा जाता है. ठीक है, मतलब पेरीफ्री पेरीफ्री के अंदर आपके पास सारी फैसिलिटी नहीं होती, ठीक है। अगर पेरिफेरी के अंदर आपके पास केस आ गया तो व्हाट आर दी मैनेजमेंट, किस तरह आपने अप्रोच करना है। सो केस वन, इफ देर इज अ हॉस्पिटल, tertiary hospital less than 2 hours and GCS is less than 8, so what you will do at this point? So GCS will be low, so you will transfer the patient to tertiary by air ambulance. Transfer patient by air ambulance. In case of second, if there is GCS less than 8 and the time travel greater than 2 hours, then you will what you will do? Greater than 2 hours hospital duration, travel time. You have to go with borehole, in which you have to evacuate the blood clot from the brain through borehole process. In case of third, when GCS greater than 8, you can if GCS greater than 8, you can go with CAT scan, CT scan also. So you can go with CT scan. These are the things you must know about that. So according to that, you have to approach. So for example, if GCS uh, if less than 2 hours, head injury in rural areas less than 2 hours and GCS is less than 8, transfer the patient. Okay. If GCS less than 8 and travel time is greater than 2 hours duration, so you can go with Barol. And if GCS is greater than 8, you can go with CT scan. So CT scan you will go when their GCS should be greater than 8. Okay. So here is guideline, RCH guideline. We will go with that. So, okay. So head injury RCH, you must go through that. So assessment, determine that there is a discharge promptly. So according to that, you have to go. For example, primary survey and resuscitate. You have done with primary survey and resuscitation. After that, assess the severity of head injury. Calculate GCS. So GCS will be either in mild head injury without risk factor. GCS will be 15 is equal to 15. So complete secondary survey if there is no injury and acting normally and child being be discharged. So discharge the patient. So in case of mild head injury where there is other risk factor is present, we will discuss the risk factor later on. So just focus on this. If the GCS between 14 to 15 and mild risk factor are present, you will go with complete secondary survey, observe for up to 4 hours. So see investigation below for decision. Either you go with neuroimaging or not. See below to detail for amendment. Okay. So in case of moderate head injury, when there is a GCS 9 to 13, you have to consult with the senior clinician. Okay. Neurosurgical team and urgent CT. When there is GCS less than 13, you will go with CT scan. So urgent CT had cervical spine and complete secondary survey as well. So secondary survey always you have to complete after primary resuscitation in every, and as well as you have to consult with senior clinician neurosurgical team. If GCS between the 3 to 8, trauma center, call to trauma center, consider intubation. Okay. So intubation as well, because we discuss if the patient is the airway is compromised, so you have to go with intubation. Consult always with neurosurgical team, urgent CT scan, so complete scan x-ray, so the things is same. So GCS 9 to 3, in between that you have to consult with senior clinician neurosurgical team as well, urgent CT scan, along with you have to go with secondary survey. And 3 to 8, you have to call intubate the patient. The point is addition. So call trauma center and intubate the patient. Okay, these are the risk factor in which You have to consider the risk factor or without risk factor. So these risk factor is present. Accordingly, you have to manage severe headache, persistent AMS, alternative state of normal neurological activity, palpable skull fracture, or there is a sign of basal skull fracture, severe mechanism, post-traumatic seizure, loss of conscious, persistent vomiting, knowing bleeding of disorder. So these are the risk factors present. You have to manage accordingly. So this is the about GCS. Yesterday class we discussed. So go through it. There is nothing. So memorize this. The total score is 15. So accordingly you have to score. So history, you will take history as well as examine the body and investigation. Neuroimaging, the need and timing of neuroimaging required should be clinical benefit, and there is radiation exposure and sedation. So these are the definitive indication. So you have to go through definitive. You have to do the neuroimaging. Definitive indication. Any moderate or severe head injury, GCS less than 13, as we discussed, you have to go with CT scan. Focal neurological deficit, sign of base of skull fracture, palpable skull fracture, suspected bacterial injury, non-accidental injury, or AMS. You go through with that. Then a relative indication. If GCS is relative indication. If GCS is 14 or severe mechanical injury, history of loss of consciousness, post-traumatic seizure, severe headache, persistent vomiting. So there is relative indication. Okay. So if there is a no risk factor or present structure, observation may be considered over immediate neuroimaging. See advice from the senior clinician. Okay. So doctor, go through that in your own time, the things we discussed. Please go through that guideline. I already attached the link in the notes. So this one table, please go through. Okay. Okay. So and then consider transfer the patient to tertiary center when all head injury, severe head injury, suspected inflated and head injury, deteriorating conscious level, focal neurological level, seizure without recovery, definite suspected penetrating head, cerebral fluid leak. So you have to transfer the patient. Mild, moderate, severe head injury we discussed, so please go through that. Okay, move to next. Doctor, any question? Is it clear so far the things we discussed? Okay, move to next. So in next we have acute epidural hematoma. We discussed in detail in neurology class acute subdural hematoma. So you have to go in even modest trauma to the side. The patient got epidural hematoma. So you will find out on CT scan. You will find out there is biconvex lens-shaped hematoma. Emergency craniotomy must be done. Okay, so emergency craniotomy and CT scan show will be biconvex. And in this patient, you will find out there is a lucid interval. The patient one time is completely fine. There is a conscious level is okay, asymptomatic. Later on, again goes in unconscious state. Later on, again go in conscious state. So like this again and again, if goes and with the passage of time, the situation is worse. So this what we called as epidural hematoma, and most of the time you will find out the lucid interval in epidural hematoma. Sometime in the subdural as well, but mostly in the epidural. So emergency, you have to surgical craniotomy. Acute subdural hematoma in baby, there is in children may be due to the baby shaken